Good evening, everyone, and thank you for joining us. My name is Michelle. I'm a product specialist here at Oculus. Welcome to tonight's clinical webcast, Tips and Tricks from the Experts for Specialty Contact Lenses. You have a text box on your GoToWebinar screen where you can enter questions. Enter your questions at any time and we will discuss them at the end of tonight's webcast. Our moderator tonight is Dr. Melissa Barnett. Dr. Barnett is a principal optometrist at the University of California, Davis Eye Center in Sacramento and Davis, California. She is internationally recognized as a key opinion leader who lectures globally and publishes extensively on topics including dry eye disease and specialty contact lenses. Dr. Barnett is chair-elect of the American Optometric Association Contact Lens and Cornea Section and is past president of the Scleral Lens Education Society. Dr. Melissa Barnett and Lynette Johns authored and edited the book Contemporary Scleral Lenses Theory and Application with the unique perspectives and contributions of international experts. Dr. Barnett was awarded the inaugural Theo Award for Excellence for Mentoring by Women in Optometry. She was granted the Most Influential Woman in Optical from Vision Monday in 2019, and she also co-hosts the popular podcast Global Eyes. I'm excited to introduce Dr. Melissa Barnett.
Thank you, Michelle. Thank you so much for the kind introduction. And I am absolutely thrilled that all of you are here tonight. And I get the pleasure of introducing my colleagues and also my good friends. So starting with Daddi Fadel, who is a lens designer and expert in specialty contact lenses. She speaks 5 languages and I think has lectured in all of them, probably in the past 1 week. She studied optometry in Rome, of course, with honors. She is an internationally recognized key opinion leader who has many peer-reviewed publications, also a few books as well. She is on the council of many different things, including the International Society for Contact Lens Specialists, a member of the GPLI Advisory Board. She is Program and Education Chair of the Summit of Specialty Contacts and is International Relations Chair of the Scleral Lens Society. She's a fellow of SLS, BCLA, and AAO. Daddi and I authored the clinical guide for Scleral Lens Success, which is available in multiple languages, available at Scleral Success. You can download it. And Daddi also authored the book, Scleral Lens Complications, the Recognition, Etiology, and Management. Next, we have Louise Sclafani, who served as an associate professor of surgery and the director of optometric services at the University of Chicago from 1993 to 2017. Her main interests include contact lenses, which is good, especially for tonight, corneal disease, and surgery co-management. She applies her experience of challenging hospital-based care as vice president of professional affairs for Synergize and continues to see patients at Solo Eye Care, a private practice in Chicago, and trains young doctors at the Illinois College of Optometry. She is a diplomate in the American Academy of Optometry, CCLRT, and selected by Review of Optometry as one of the top 10 females at the forefront of optometry, which is very impressive. Dr. Chandra Mickles is an associate professor at NOVA, Southeastern University College of Optometry, where she is director of the Dry Eye Care Center, instructor of record of the specialty lens course, and an attending in the contact lens clinic. Dr. Mickles lectures and publishes extensively in the areas of contact lenses and ocular surface disease, and is a recognized key opinion leader. Now, some fun facts about Dr. Mickles. She was recognized by the NSUCO students as Professor of the Year 2 years consecutively, and in 2018 was named a top Black educator in South Florida. She has been featured on media outlets such as ABC News, the Miami Herald, and the Sun Sentinel. So welcome, all 3 of you. I couldn't ask for a better group. And this is going to be a really fun, hopefully some knowledge will be shared as well, but a conversation. We're going to talk about various things that we're doing right now, and also we're going to look towards the future. So if there are any questions that you have, please feel free to type them in the question box. So next slide. So we know the importance of data. And now more than ever, we're learning so much about scleral shape and to understand the sclera better, especially when we're fitting all sorts of contact lenses. So not only scleral lenses, hybrid lenses, specialty soft lenses. We have these wonderful tools where we are learning about how scleras are not all normal or regular. According to the scleral shape study, almost 70% of eyes have shapes that are not spherical or toric. They need very quadrant-specific designs and information. There are also many studies out there that are looking at scleral shape and showing us that there are differences amongst different ethnic groups. There are differences where patients who have highly irregular corneal astigmatism also have an irregular scleral shape. So I'm going to ask the panel here, based on these studies, how important is it to measure the entire eye, including the sclera, as part of a scleral lens practice? And Daddi, I'm going to start with you on this one.
Why, great question. I think that it depends on what scleral lens practice you want to build. An advanced scleral lens practice is based on more likely asymmetric scleral lenses, as you said, because sclera are more likely asymmetric, and so customization that fit every single eye is needed. In this case, yes, you need to measure the entire eye to tailor every lens, which is different between right eye and left eye. So you need the technology that allows you to map the entire eye and to customize scleral lenses. Definitely.
And Chandra, to back that up, because you're teaching students, and you know, what are you teaching students both in school, and what are you teaching them as they go out? And I guess Louise, the same question to you too, since you're teaching as well. I'll let Chandra go first.
Yeah, we just had a lab this past week on the importance of corneal scleral mapping and how tremendously this can help improve efficiency and fitting. I mean, I think the time will come where we'll be wondering how we ever did fit lenses without this technology.
Louise, what about you?
Well, I was just going to say we are fitting lenses without this technology, and I'm going old school right now because most practices don't have the luxury of having these instrumentations. It would be great if we all did in private practices, and as I've worked in hospital settings, optometry schools, and now private practices, they do quite well in private practices without having that technology, and the technology becomes the examiner or their eyes and looking at a lens that perhaps on the sclera that doesn't have any specificity to it, but then making judgments at that this particular patient does need more specific lens designs for them. So
do you think it's a combination perhaps of, you know, diagnostic fitting and also checking scleroprofilometry? So I'm going to ask this question to all three of you, starting with Louise. So do you think that scleroprofilometry will become more common in the next, say, 5 or 10 years?
Well, I think it has in the past few years. Yeah, I mean, a couple of years ago when we would talk about this, there was only one instrument available, and now there's several. And you know, as we could make adaptations to the topographers or any other instruments that we have, if we could make additions to them, I think it'll be easier for practitioners to get them. So I think, you know, there are a lot of different types of scleral lens fitters. We all know that. There's those fitters who might be fitting an eye that will benefit from a scleral lens, but might not have as many irregularities. And then there's the train wreck patients that we all see too, who will really, truly benefit from having that technology.
And Daddi, what do you think?
Well, I personally think that, of course, I'm definitely convinced that this technology will be increasingly common in the practices. It's exactly the same scenario of corneal topography that get common with time, and now most
Yes.
practitioners have corneal topographer. And I wonder, how could you optimally fit a corneal lens without a corneal topographer? So yes, you can, as Louise said, that you can use your scleral lens diagnostic set to attain an optimal fitting, but how much time, how much chair time you will consume to get the final lens, and how much lenses you need to reorder to get the final lens, how much money you will spend in reordering lenses. And in the meanwhile, your patient will get stressed and perceive a non-experienced practitioner in you, and she or he would trust another practitioner who have advanced technology, and maybe practitioner who will find faster the final lens, even if the lens will be slightly more expensive.
Chandra, anything else to add?
Yeah, I couldn't agree more. I think that we probably couldn't imagine now not fitting specialty lenses without a corneal topographer at least. And I think what holds practitioners back from fitting specialty lenses is the chair time. So a tool like this would be something worthwhile to invest in. I think more and more over the years, more clinicians will see the value of investing in this technology so that they can save chair time and serve more patients.
And next slide, excellent points here, all three of you. So these are just some images you can see of scleral shape. This is going to the scleral shape study group that shows that scleras are very non-rotationally symmetric and can really benefit from those custom back surface haptics. And next slide, please. And we were touching on the different technologies that are available, so just highlighting the technologies that we have now to measure scleral shape. We have the three different technologies, the Eaglet Eye ESP, the Visionary Optics SMAP 3D, and the OCULUS Pentacam Cornea Scleral Profiler. And if you just move on to the next slide, you can see an image here. So this is actually an image of a ScanFit lens that is taken with the Pentacam CSP. And for those of you who are not familiar, and just to share some basic information, this can image the entire ocular surface in primary gaze, so you don't need to look in different directions of gaze, just straight ahead. It can go out to 18 millimeters. No fluorescein is required and actually should not be used. And then the information is all exported and freeform lenses can be designed. The Pentacam data that we all know and love can also be used as well and is populated into the displays. So I do have another question for the three of you, final question on this. Do you think novel scleral lens designs will be created based on scleral shape information moving forward? And we can even think outside the box of things that don't exist right now. You know, can you see some new technologies that will help so that more practitioners can have access to this information? Daddi, I'll start with you here.
Yes, I think that definitely it will be this case. We are fitting the sclera, so it's essential that the lens properly align with the shape of the sclera for comfort. So let's remember this comfort. Scleral lenses offer more comfort compared to corneal lenses. But if the lens doesn't align properly, comfort is compromised and the risk for dropout is incredibly increased. Also, a lens that is not fit properly compromises vision, which is the second reason for dropout after comfort. And let's remember another factor, that dropout in scleral lens practitioner can be dramatic for the patient. Dropout in these patients promote eye surgery, depression, psychological problems, and emotional instability. So it's important to consider that a good lens alignment prevents issues and complications and dropout.
I agree with what Daddi just mentioned. And also, you know, as this technology has allowed us to learn more about the scleral shape, it's given the industry, the contact lens industry, and those who design lenses the ability to you know, utilize this. Now there are there's several different lenses, scleral lenses, hybrid lenses that utilize the fact that there's linear expectations outside of the sclera. It's not so curved. And so I think that there has been this shift in redesigning lenses. So it's novel, but it's here. It's already, you know, present. And so I think it's important that this technology that came about is what's helping designers make new lenses that are more conform to the scleral shape and lead to success, like Daddi said.
And I'm going to chime in before I get to you, Chandra, that Daddi, when you were mentioning comfort and I, you know, I'm just thinking vision, and of these patients I've had where I fit them with a scleral lens prior to this technology, they're seeing 20/20, but it's not the quality of vision that they want. And then having the lens sitting more precisely, fitting the eye better, the quality of vision is much improved. So could be that correction of higher order aberrations or getting it centered better, that 20/20, it's now, you know, a 2015, a 2010 even, which is crazy. And they're so impressed by that. Of course, always really helpful for scleral multifocals as well, to get the lens as centered as possible. I'm actually going to.
I think you guys covered everything.
Yeah, I'm going to move on to the next slide, and just wanted to show you, this is an image of a wave lens using the Pentacam CSP. So again, there are many options out there of different lens designs and technologies, and even for a patient where you think that they're fit very successfully, if you fit them before, I think we've all had the experiences of wowing that patient with the new technologies. And now we're going to move to the next slide in a different subject about keratoconus. And we know that there have been many studies on the prevalence of keratoconus, and the study that has been around for many years, based out of Minnesota, of course, looked at retinoscopy and keratometry outcomes, and that's that 1 in 2,000 number. So let's talk let's touch on retinoscopy in just a little bit too, because that's one of my favorite topics for talking about keratoconus. Then moving on to 2017, a study out of the Netherlands of 4.4 million patients showed that 1 in 375 patients were diagnosed with keratoconus. And then, of course, the recent RAIN study from Perth, Australia, that used the imaging from a Pentacam showed 1 in 84 patients had keratoconus. So let's start with just say we don't have any technology at all. We're on a desert island, we have a slit lamp, and what was that drink you're talking about? We have the drink, and then we have a retinoscope.
An Aperol spritz, yeah.
Okay. So, yeah, and then we have patients who are coming to our desert island. So how many of you are using retinoscopy to diagnose patients with keratoconus? Even if you didn't have, say you didn't have any of the fancy technology, is that a tool that you're using today?
Melissa, it's without a doubt, it's still a good tool to have when you could find your retinoscope. Fortunately, we still use a retinoscope, but you know, and I will tell you, when I first started practicing at University of Chicago Hospital, I didn't have an autorefractor. I didn't have any razzle dazzle, and so retinoscopy was my autorefractor. And it was always exciting when you could make that diagnosis. It was either that or an oil droplet cataract. I remember, you had to go either way, and then you're just like, now I got to measure that cornea. But I think that it's our duty to keep teaching students to use that, because you never know where you're going to be practicing. You're never going to know when a piece of equipment's going to go out for the day, and you have to have a backup. And I think it's great. Seeing that scissors reflex is just like, there you go, we got it.
I definitely agree, and not only for diagnosing keratoconus, because sometimes it's quick, it's easy, you can do it, but also if a scleral lens is on the eye and you want a starting point, retinoscopy is super helpful.
Oh yeah,
Boom,
teach
boom,
my students
there we
that
go.
every
This
year.
is where we start. You know, definitely, and of course all the other reasons as well.
You know, another alternative thing is also, you know, when you're doing a dilated exam as well, and you're looking through your 20, you can really see the outline of your corneal, you know, where the apex is, and that's always an interesting way of looking at it too. Again, alternative to modern technologies, just looking at that reflex through dilated pupils, great.
Definitely. So getting to the studies here, I would really like all of your opinions, and I'm sure we all have practices where we're seeing many, many patients every day who have keratoconus, and I'm always shocked when my patients have never met anyone else with keratoconus. If there's no family history, they've never met anyone, and they ask me, is it common? And I say, it's incredibly common. So I have my own opinions on these studies, but Chandra, what do you think? What do you think of the results of the most recent study, the one in 84?
I think the study was well done, and I think it brings to our attention on the importance of proper diagnosis of keratoconus early on, and how we can utilize these tools to help us with that. You know, when we started looking at the studies back in 1986, I just couldn't believe that was true by the number of patients that I see that have keratoconus. I just couldn't imagine that. So I think we're getting closer and closer to accurate numbers of the prevalence of this condition.
I think the question is, has it always been there and we're just detecting it now? Or has something in the environment changed it, and so we are getting more incidents of keratoconus? And I think it's a combination of both. And I remember when I first started practicing, again, it was just so rare. And now I mean, obviously we all have specialty clinics, so it's not rare to us at all. We see, you know, half of our patients are like that. But I think patients are, I think social media and the National Keratoconus Foundation and International Keratoconus, okay, they're bringing it to light, so patients are becoming more aware of the condition, and so we're looking for it a little bit more. But without a doubt, it's the technology that's allowing us to find it.
Yeah, I think that before the availability of corneal topography or advanced technology, the studies have shown low incidence of keratoconus. So actually, incidence and prevalence of keratoconus are characterized by wide variation, probably attributed to regional and ethnicity differences, healthcare accessibility, difference in scalability, and also increase of availability of new technologies in corneal imaging, allowing a better accuracy in the disease. The Dodge report has shown the incidence and prevalence of keratoconus 5 to 10 times higher than previous studies. And referring to the authors, this difference may be due to several factors. The first one is the increased availability of technology in the diagnosis of keratoconus, and the second one is the presence of Asian immigrants in the country, which represents about 22% of the population. So the new technology of corneal assessment have allowed a greater understanding and early recognition of corneal disease. This has an important impact. This study has an essential, very crucial impact on public health and national health system in some countries, because this prevalence, keratoconus, should not be anymore considered a rare disease.
Yeah.
So this is very important.
Right. Oh, definitely. And then, of course, I know we all know this, but diagnosing early is so important, and including cross-linking early prior to progression and preventing corneal transplants. And of course, there have been a few really great studies out there showing the benefits of scleral lenses to prevent corneal transplants too.
Mhm.
So there's, even in the last 10, 15, 20 years, there have been so many advances in this field.
Yes, lenses have shown also to increase the quality of life of patients with keratoconus.
Yes.
Oh,
Well,
yes.
I think,
Did a study on that.
we used to tell patients that about 22% of keratoconus patients are going to go on to need a corneal transplant. We would say that 20 years ago, and now the number is so much lower, again, because of better contact lenses as well as cross-linking.
Cross-linking.
And Melissa, I thought it was interesting that you brought up retinoscopy because, as you know, diagnosis of keratoconus was based on what? Retinoscopy and corneal thinning when it was like so late, right? And now it's based on so much earlier findings, back surface cornea, changes in the thickness distribution. So I think that I mean, again, that the diagnosis, I mean, these cases may have been there. We're just seeing them a little bit more frequently because we can find them more. We could find it easier. Also, the whole concept of, rubbing and being a contributing factor to keratoconus, rubbing and inflammation, and there's probably more allergy there today than there was 20 years ago. So there's another contributing factor to this.
Right, atopy and allergies and the vigorous eye rubbing. I think, as we've discussed, genetic testing is going to be really interesting to get earlier. And then, of course, I feel always very spoiled with my Pentacam, where I can image the back surface. I really do every day. I'm like, oh, I can see that back surface. I can't see it without my Pentacam, and to catch the early keratoconus. So
you feel like a magician when you have that, right? Because because we're seeing it, that's where it begins. You're like, how come you found it? And my doctor down the street didn't find it. How did you find it? So it really does set you aside, as Daddi was saying, when you have different technology and you can give the patient the answer to the problem faster than and the correct diagnosis, it does make a difference for them.
Definitely.
Yeah, it really sets you apart and makes you they're your patient for a lifetime, really.
Mm-hmm.
So when do you discuss cross-linking with your patients? I'm going to throw this out to the first one who gets it because I'm having so much fun with it. Better move on to the next question.
I think for all of us, I mean, we know it's such a great, rewarding opportunity that we have to enhance and restore these patients' vision, but it's also important to ensure that we maintain their sight. And so we're really fortunate to have cross-linking available to, prolong or prevent them from having to go through getting a corneal transplant. I would say for all of my patients that have keratoconus, I at least make them aware that option is available for them.
Yeah, I think as soon as I make that diagnosis, we start talking about it. I mean, it used to be I would tell the patients you're either going to wear contact lenses the rest of your life or need a corneal transplant, and you have to add cross-linking in there. And of course, the question they ask you is, am I going to go blind? And you're going to say no, because we have all these options, and we're going to slow down the progression of vision debilitation by cross-linking potentially. So
yeah, and one really nice thing lately is the price of cross-linking and coverage has improved so much. The price has gone down, the coverage is better. I think in Italy, Daddi, isn't cross-linking some very reasonable amount?
Yeah, it's a reasonable amount. And now with this, the result of these studies, the health system, the national health system should consider that and should provide patients with this technology, with this intervention of cross-linking, because of course, keratoconus is not anymore a rare disease, and I agree with Louise and Chandra. I discussed the cross-linking option as soon as I know that he or she has keratoconus. The fact that patients' mental status declines also as keratoconus worsens, so this justifies the consideration of cross-linking during the early stages of the disease. And cross-linking, just like skull lenses, has shown to reduce anxiety in keratoconus patients and to enhance quality of life of patients of keratoconus. So I think that cross-linking should be done as soon as possible.
Yeah, Daddi, going along with the quality of life studies that you've mentioned, you know, they have likened it to being worse in macular degeneration because you're diagnosed with it so much earlier in life. You have so much time ahead of you, and you're diagnosing it sometimes a teenager, right? Or, you know, mid-20s, and they're looking at their potential to make money for the future, driving, all that kind of stuff. So it really does. And so to be able to offer cross-linking, and so they don't see that's the road they're going to go down is really rewarding, especially if the parent has cross-linking. I'm sorry, has keratoconus.
Yeah.
And I think, you know, we all want to screen those kids of keratoconus patients, but I think it's a much easier discussion to have with that parent. I know they're all like, wow, this is new. I've never heard of this, but you have something for me, something more than a little piece of rock you're going to throw in my eye because they're used to corneal GBs maybe, you know, so. Yeah.
I think we all can agree.
I agree. It's so important to have that conversation with the parents and the child. You know, just looking at all of the studies on personality in keratoconus, we did a review study of personality in keratoconus, and exactly as you said, Louise, it's the timing of diagnosis. So we found there's no true personality. Well, that's what the studies say, but it's really the timing when keratoconus is diagnosed. So the person could be, you know, in their mind just completely normal. Everything, you know, is going smoothly, and then there's a huge diagnosis, typically in the teens or early 20s.
And it really helps us to do the best for them, because I think Chandra mentioned, you know, these are our patients for life. And I think I'm older than all of you. And so I've had patients for life for over 25 years, and I've seen them change over time. And Lord, you want to keep them happy. I want to keep them happy and away from a transplant as long as I can. So
I think all of you probably experience this like I have. It's kind of like this sense of relief when I tell them that cross-linking is available. There's another option that can slow the progression of this disease, that they're not going to go blind, and that they may not need a transplant.
Definitely. So Chandra, for your patients that have been cross-linked, when do you fit them with scleral lenses? How soon after, or does it vary?
It somewhat varies. So I work a lot, of course, you know, I'm in South Florida, so I work a lot with Baskin Palmer and Bill Trattler. And usually I would say around the 1 to 3 month mark. Of course, usually the 1 month mark with the epi on. Trattler does a lot of epi on, so he usually sends them back like around a month. Because I think the thing is, you know, our patients, we all have them, they panic without their lenses. So if they can get back in their lenses as quickly as possible, they'll want to do that. And I feel like at that stage, the cornea is at a state where we should be able to at least fit them in a lens like a scleral lens that will not touch the cornea and cause complications.
And Daddi, what about you? Is it the same in Italy or is it different?
Well, in Italy, optometrists should wait for the ophthalmologist, to fit the cross-linked cornea. So it depends on the cases, and they suggest us when it's time to do that. We cannot decide that for our own.
And what about you, Louise? Is it different in your case?
No, I agree with Chandra, but also I, you know, let the patient know that you might undergo a couple lenses till we get it right, because the cornea over time is going to be changing. Actually, you know, steepens up a little bit. So initially, so we need to make sure they're aware of that. I think Clark Chang did a study, and he showed that over 90% of them are fit though with a second lens, up to a second lens, and almost all of them with a third lens. But I think he mentioned in a study that they did over in New York and Jersey or wherever he's at. Sorry, Clark, I can't remember where you are.
Jersey, yeah.
Yeah. So we just to prepare, but our patients are prepared for that too, that they might undergo a couple changes.
Yeah, all excellent points.
So, and the other thing is, if you are catching them early, I mean, this is the beauty of doing cross-linking. We're doing it on earlier cones, hopefully, and they become patients who don't need to maybe be fit into scleral lenses. They could wear soft lenses, specialty lenses, hybrid lenses. So as long as, that's the benefit of doing cross-linking early, is they have more options in front of them then.
Oh, definitely. And even glasses in some cases, although it's important to stress that cross-linking is not a refractive procedure, because I have many patients that think that, oh, it's like refractive surgery, where I'm going to eliminate all of my options, so I don't need to wear contacts anymore. So having that honest discussion is really important. So I'm going to just remind the audience to, if you have any questions, please feel free to type them in, because we are going to answer more questions towards the end. But now we're going to move on to the next topic that we're going to discuss. And the next slide, please. So when we're fitting scleral lenses for ocular surface disease, we often have this issue of poor surface wettability. So as you can see on the slide on the left, this was a patient of mine who came in. That was the anterior surface of her lens. So obviously she could not see much through that. The other picture that you can see that really filmy surface. So I'm going to just have you move on to the next slide, please. So Chandra, we actually published a manuscript on this topic, where we looked at scleral lens wearers with dry eye with a PEG-based surface treatment compared to untreated lenses, and demonstrated that those who have dry eye had improved comfort, resolution and relief of dry eye symptoms, and reduced ocular surface compromise. So I'm going to let you start off with this one, if there's anything you want to mention about the study, but also just in your clinical experience, what recommendations do you have for patients with front surface fogging?
Well, just starting with the study, I love that I know all of us are probably using this surface treatment for scleral lens wearers with dry eye, but there was no real evidence showing that it can improve comfort, dry eye symptoms, and signs. So now we have the support there and evidence for us to use this coating for those patients and for all patients that wear scleral lenses and other specialty lenses. As far as other options, I mean, this is not the only option, but it's a great option in order to prevent poor wettability of lenses. There are other things that we can do, and I think the key thing is being proactive instead of reactive. I'm sure each of you have been, colleagues have reached out to you and asked you, okay, what can I do now, right? And with this poor wettability or deposits on the lens, it's more important to be proactive and say to the patient, you need to partner with me in order to have success, in order to reach our goal of having optimal outcomes and have good comfort and clear vision with the lenses. And some things that I go with the patient, is making sure that they properly clean and replace their plunger every month and their case, and use proper disinfection, such as, a preservative-free disinfection solution. Also go over simple things, just keep it simple, using oil-free makeup and not using soap that has a lot of creams and lotions in them, and simple things like putting your makeup on after you put on the scleral lens, and thoroughly wash your hands even before you remove the scleral lens. So those are key things that I think we focus so much on the special and the technologies, and we forget about the importance of educating our patients on these simple things that can make a difference. And of course, being aggressive with the management of MGD, of course, because that's a key culprit of this issue.
Definitely agree with all those points. You know, I always say managing the eyelids to your maximum level, like top 100% what you do. Daddi, I saw you nodding there. I think, is there anything else you want to add? How do you manage patients, the front surface wetting issue?
Well, yes, I agree with Chandra. I check the care regimen, the plunger hygiene, hand soap, cosmetics, and the use of lotion. Plunger should be disinfected after each use. So again, education, patient's education. Make sure the plunger is dry before use. So this is important to tell the patient about that. And I would recommend them to avoid soap containing lanolin, moisturizer, or oil. Switching to soaps indicated for acne treatment or contact lens use. Maybe to use non-preservative artificial tears. Avoid cosmetics inside the eyelid margin, and also diet. So I would recommend them to include omega-3 and avoid fats and fried foods. And of course, add plasma treatment and either hydropack.
And lots of good EVU, right? Extra virgin olive oil. Skip all that fried food.
Tastes good, but no, not good for.
I think it's important also to just like really listen really hard to your patient. So I had a patient 2 weeks ago, and we had just dispensed, they weren't sclerals, they were hybrid lenses. And she was saying how after a while she gets this fog, it just comes over her eyes. And I'm like, that's, you know, okay, let's go over everything, right? And as I'm talking to her, so she didn't come in wearing lenses. So I looked at the lenses, they look clean. I had her put them on. And as we're sitting there talking, I could actually see this building up. And so then I started just going through everything Daddi and Chandra just mentioned, hand washing, creams, blah, blah, blah. And you know that there are some like nasty patients who you just know don't wash their hands. This is a COVID nurse. This is a nurse in the ICU, you know, at UC. And so she is constantly washing her hands, right? And then I'm thinking it's her mask that's filling it up, you know, so like this is a different time that we have to start thinking about with our patients. Are they getting things on their eyes because of their mask? I mean, I think they're doing better by wearing contact lenses than their glasses. I can't go out of the house without my contacts on now. But I also, we all know that we're seeing more lid disease because of these masks. How many chalazions do you see? I have a chronic one. I've never had one in my life, but since March, it keeps coming and going, coming and going. So we know there's something to that. But I didn't see any of that going on in her eyes, you know. But the thing that she did have was this new eyeliner, which she was respecting. Yeah, she was respecting the mucosal line, but she said it was new. And I had ordered a brand new lens for her. I was coating it. I had it coated with PEG. You know, I was having everything, you know, and I was like, I really thought this out. And she calls me up like 3 days later, you know, I stopped using that liner and it worked. You were absolutely right. I'm like, did I say stop using that? I don't remember that, but I must have said that, you know. And so, yeah, so those little things, you know, she must have just said it like 1 second. She said it, and that was it. It was her liner. So
these are all just excellent points, and I know you're all also detectives like I am, you know, just trying to figure out what it is. You know, one has been soda, drinking a lot of soda, changing that just, you know, completely changed it. Another one was the fried foods. Another one was changing that, like even the makeup remover, like the soap. And so just going through every single thing systematically is so important. So hopefully these patients can be wearing their lenses all day long and not needing to remove them and reapply them. But on kind of like a standard basis, are you recommending to your patients that they actually remove their lenses and reapply them during the day?
I wouldn't do that as a standard. It's not like I don't like dispense the lens and say, go home. Now, don't forget, take it out in 8 hours, wash it, put it back in. You know, I take it as almost a failure. I think I must have done something wrong with the landing zones or something. You know, I try to do a fix, but there are some people that you can't, and so rather than take it out, sometimes I have them just do one of those, surface rubs with a Wexel sponge. I think that works great, but I don't know. What do you guys think?
Yeah, totally agree with you. I would avoid telling them to make breaks during the day. I think that with some patients, this procedure worsened the fogging of the anterior surface.
Yeah.
Only when fogging is significantly compromising visual acuity, I would recommend them to remove the lens, to wash it, to disinfect it. I would rather recommend, as Louise said, to use a plunger or cotton swab to clean the lens surface while the lens is placed on the eye.
And especially now, and even before COVID times, patients don't like to go to a bathroom that is a shared environment and remove and clean and reapply the lens. Chandra, you were saying?
Yeah, I was just about to say that. And also, since I see a lot of patients with ocular surface disease, I agree with Daddi just said. I do see that it makes it worse the more that they remove it. So you're definitely disrupting that ocular surface, which we do not want to do. But I do also want to say, keep in mind with these patients that, if you did it once, I think that is okay, because remember, in their tears, there's a lot of inflammatory mediators, and maybe there'll be a benefit of just removing it for that reason, but no more than once a day.
Mm-hmm.
Excellent points. Moving on to the next slide here, a very highly debated topic, and just clicking one more time. I think if you click it one more time, yep, there you go. Do you allow your patients to rinse not only scleral lenses, but corneal GP lenses, any sort of lenses with tap water? So that's the first question. Why don't we start there, and then we'll move on. So Chandra, go for it.
Definitely not. I think you guys know I'm a part of the CLAY group, the contact lens that's in the youth group, and we've done a lot of work in this area looking at risks associated with the wear and care of lenses. One thing that we did find, believe it, I don't even know if it's shocking or not, but 90% of GP wearers rinse their lenses with tap water today. That study was only a couple years ago. So we definitely need to be proactive in educating our patients on that. And the why, yes, there is a low risk of developing acanthamoeba keratitis from rinsing with tap water, but the results are devastating, right? The outcomes are devastating if they do develop AK.
Like blindness, loss of the eye,
Yeah, just that.
Devastating, yeah, definitely.
So being from Chicago, we were the epicenter of AK when it came out, when we had that, the incidents with soft lenses. That was when I was president of the AOA cornea and contact lens section, Melissa. So I hope you don't have a pandemic well, I guess you do. But anyways, so yeah, tap water is a no. But I will tell you that our colleagues always, not always, but often use tap water to clean their trial lenses or a patient's lens. And the first time you do that in front of a patient and they see that, they think it's okay, right? Yeah. And I remember, I believe it was either Loretta Shaka or Christine Stint, one of them mentioned that they read an incident of a patient seeing the doctor doing that, and they later developed AK. That doctor was brought in because of they thought the doctor did it, and the patient went blind, not from the doctor, but they just went home and did it on their own. And the patient lost vision from acanthamoeba. So, what we do in front of our patients is really, really important, what we do. So, no tap water. No.
And not only us, but also our staff. We need to.
Yeah.
Too.
Yeah.
Daddi?
Absolutely not tap water. We have enough evidence that's showing acanthamoeba associated with tap water, so definitely not. I agree.
which gets us right into the new technical report for guidelines for handling multi-patient contact lenses in the clinical study. So these guidelines were just published in 2020, and it comes along with a very handy in-office tool that you can use on the right. So this is widely shared with everyone because we want everyone and to have best practices to ensure patient health and safety. So part of the disinfection for the gas permeable aspect is soaking a lens for 3 or more hours in hydrogen peroxide, that's 3% in a non-neutralizing case. And I know that colleagues have come back to me saying, well, that's, a pain in the neck, the 3 hours, it takes a long time. And so, Louise, how is this working in your clinic and with your clinic flow with just the new guidelines in general?
Yeah, well, it's pain, right? And it'd be nice if there was, you have to develop a system in your office, and my interns are my system. I'm lucky to have that. But, and I've had to, for my most commonly used trial lenses, I've gotten some duplicate lenses so that I can do multiple fits. I will tell you, this came right at the perfect time of COVID, right? I mean, Melissa, you and I and several others, when we were writing this, how could we have predicted that COVID was going to happen right after this? I mean, we've been working on this paper for a long time, and then COVID hits, and it makes it even more important, right? And so I think that, again, just timing, looking at your schedule, saving the lens if that you need it for that patient. I don't, between patients, if I need to put that lens onto the other eye, I don't do the disinfection process. Probably shouldn't have said that out loud, but I don't. I think what it is this is going all the way right around to the beginning of this discussion, and that is empirical fitting. Or fitting, and that we all have to be very open-minded and available, and keep that, know that that's probably where the trend is, to go either with disposable scleral lenses that can be used for diagnostic lenses, right? Or using technology to make that first lens, or just doing everything empirical with like either specialty soft lenses or hybrid lenses that can be fit empirically without putting any lenses on.
And Chandra, do you have the luxury of students in your clinic?
Yeah, the same. It's probably a similar process that we use that Louise uses. I think the challenge, and I don't know if any other people in academia are listening, has been the laboratory as well. I mean, we're using GP lenses to teach our students in the lab, and so that caused some disruption. And similar to clinic, we just ordered duplicate sets. I even for my students ordered each of them a set, so they have their own set to use on their own eyes.
Yeah, it's getting very costly for industry too, to be providing lenses for students to have, but they need to learn how to use them. So
definitely. So we have a ton of questions. This is awesome. So thank you. So I'm just gonna start with the audience questions. So the first one is there an age at which you're able to detect keratoconus? Who wants to take this one?
Well, traditionally, I'll take this one. Traditionally, it's been a disease of puberty, right? But we actually, at ICO, we have a study where we're screening kids in the inner city of mostly African-American and Hispanic backgrounds, and we're seeing early detection using Pentacam and the Bell and Ambrosia tools to pick up early keratoconus, and we're getting it at much earlier ages. We're picking it up at 8, 10 years old, and we're seeing it in 7% of the population that we're seeing. The risk factors, not the full-on keratoconus, but the risk factors for them to develop keratoconus. So, so I think any age is up for grabs. Remember, there are more keratoconus patients out there walking around with probably soft toric lenses or just undetected. because they're passing their school screenings and you have to find it. And often, you know, those cones are just, they're located below the pupil, right? And so they might be just regular astigmatism until we pick it up with a topographer. So.
And thank you for bringing up that study. I'm so excited to see it published and to see all the ins and outs of that study. I think it's so important. And don't forget, you know, the family history, of course, is so important as well. And then the genetic testing. Chandra, I'm gonna put this question for you. It's asking in patients with severe dry eye, how does the scleral lens interfere with dry eye treatment? Is the question.
I mean, you just got to be proactive in making sure they're following a treatment protocol. So I always give them a take-home sheet, exactly step-by-step what they're going to do as far as their drops. And I'm assuming they mean as far as when they're going to instill their drops. They know that they're going to instill their immunomodulating agent, whatever it is, whichever one, before and after they wear their scleral lenses.
And do you allow artificial tears over the lens?
Oh yeah, for sure. I use preservative-free artificial tears over the lens. And sometimes I'll have them place a drop of preservative-free artificial tears in the bowl of a lens as well.
Like a thicker, more viscous one that could help. And then, of course, with the eyelid management, you could do that either before or after.
Exactly, yeah. It's pretty easy for them to follow, yeah.
Definitely. So Daddi, this next question's for you. And I don't know if you have the statistics or just in general, but without scleral profiles, how many lenses does it usually take to fit the lens? Compared to using scleral profiles, what is the average number of fittings?
Well, I think that the average of lenses when using the profile of the sclera is 1-2. Without using that, it depends on your experience.
Yeah.
It may be 4 or 7, 8. I don't know. It depends on your experience in making changes and understanding what changes you should do. You should make to the lens. Of course, without the profilometry, of course, you need much more experience. With profilometry, it helps you to understand where and how to make the changes immediately, and you reduce your time, your share time, and the lens is ordered.
Very good. So I'm going to ask one audience final question and then one other question to each one of you. So this could be for anyone from the audience. Have you found a medical need for cosmetic surgery, such as a brow lift, to improve the fit of scleral lenses?
That's a great question. I've found that a lot of patients with ptosis don't need a ptosis repair after they get fit with a scleral lens because it does open the eye. That has actually been a reason for some of my patients to have it. I have again, keratoconus patients are your patients for a lifetime, right? And I have a patient in her mid-70s right now, and she just had cataract surgery, and she's getting a lot of droopy lids, and years of doing this, right, are causing her to have that ptosis. And so I really want to fit her in a scleral, and she's frightened because of the size. She's intimidated by it. And I'm like, but look what, so I put it on her, of course, and I wanted her to see it. And she's like, something looks different about me. And she saw how her lid was lifted from the lens, and she was like, this is amazing. So I think the opposite of what you just, of what the question is, how I answered it, I guess.
And now that we have oxymetazoline hydrochloride, the eye drops to stop the eyelids, that also can help. But scleral lenses, can help with ptosis, and that has been shown too. But especially for our patients who've worn corneal GPs for all those years, and Louise, the patient who had cataract surgery with a lid speculum, and they have some ptosis, have drops that can help that as well, which is great. Okay, quick final.
Is it available in Europe?
Not yet.
Oh, not yet, yeah.
Yeah, just September 2020, it became available in the US.
Okay.
It'll come. It'll probably come soon everywhere. So Daddi, I'm gonna start with you because there were some questions on fitting, but I'm gonna ask this to each one of you. The final question, but Daddi, to start, in your opinion, what is the single most important pearl that you can share for a doctor considering starting a scleral lens specialty practice?
Education. A lot of education. Well, I think that the objective is to attain a level at which you are able to know how to manage fitting issues and complication when they occur without consulting the lab. So here a lot of experience is needed, education, and of course refer to some articles and books. I would give another advice to start with one fitting set, to get used to the terminology, the fitting process of that set, and when practitioners feel they got more confidence in fitting scale lenses, knowing all the changes they should make to the lens, or may need customization that that set do not provide, they may need to have a second set. And when they will get two sets, they should have different lens diameters for the two sets. And another recommendation is to take notes of every issue they encounter, their considerations, and the management that allow them to resolve the problem. This is very important because it's indeed learning from complications and from your own errors.
Excellent points. Chandra, same question to you. One tip.
I think Daddi took it all, but yes, I would say continuing education, not only for someone opening a new specialty practice, but for all of us. We know that what we know about specialty lenses is changing at a rapid pace. For like every month, something's coming out. So we really have to stay up to date so that we know how to properly fit these lenses and prevent complications. And not only education for ourselves, but also educate our staff and educate our patients properly.
Excellent. And Louise, one tip.
So I agree with everything that was said, but this is my main point. Live with no regrets. That's my 2020 mantra, is no regrets. And my regret is that I started fitting scleral lenses later than a lot of my colleagues did. And but it's never too late to start it now and follow all the direction that everybody else just gave you, and don't have any regrets, because if you don't fit them, you will.
Yes.
Well, thank you all. This was absolutely fantastic. And we actually had an international audience to attend tonight. Daddi, thank you for speaking in the middle of the night. We greatly appreciate that. And for all of you, thank you so much for your time and attention. And to Oculus, thank you so much for having us. So we greatly appreciate it.
Thank you, Melissa, for putting us together.
Yes, thank you, Melissa.
Thank you so much.